We'll start with our first guest speaker, Nada Hotkins. Nada is a passionate registered nurse and international board-certified lactation consultant with 14 years of experience caring for breastfeeding families. When Nada became aware of the power of prenatal hand expression, she left her job to make her primary focus in introducing this life-changing practice to more families and healthcare providers. She lives on a farm in Saskatchewan where she works alongside her husband. She is grateful for her family and all they do to support her calling. She has been traveling to several countries, sharing more milk sooner resources, research, and insight with breastfeeding families and healthcare practitioners and providers.
Thank you, Julie, for that beautiful introduction. As Julie mentioned, I am joining from by North Battleford, Saskatchewan, which is just north of Saskatoon, Saskatchewan. And it's kind of success story that we in Saskatchewan are coming to kind of share our experience with prenatal hand expression, antenatal hand expression. I tell all of my Ontario friends that we have a very small population of just over 1 million over our whole province. And so we don't have a lot of abilities to make beautiful resources, and Ontario does so many beautiful things for so many things, Matt Child. And so we shamelessly steal from you guys. And so it's a privilege to be here returning some of the favors for the wonderful work that you guys do. You can connect with us on any of these platforms. And joining with me today in spirit is our two obstetricians. So More Milk Sooner is a grassroots initiative started in North Battleford and Saskatoon, Saskatchewan by myself and two obstetricians who have a keen focus in helping women have an easier time starting and continuing to feed their babies. Interlaced throughout this presentation, we are going to have some beautiful pictures of mothers from Onion Lake Cree Nation, which is about 2 hours north of where I am. And they got together and put together a book about hand expression. And so I can connect anybody who would be interested in that book to our nurse there. So first, what is hand expression? This is always the part of the presentation that it's a picture's worth 1,000 words. So we're going to watch a clip from a video that we did specifically for prenatal hand expression. One thing to know is that when we hand express before baby comes, we're expecting to get very, very small amounts of it. And so every video that was out there was after placental delivery, where milk volume would be much higher with hand expression. So one of our first tools and tasks we needed to do when we started More Milk Sooner was to develop a video demonstrating actually prenatal, because prenatal is small amounts and it's very discouraging to mothers to watch videos that are of after postpartum hand expression where milk just kind of comes out so easily. So I'm going to let this mom show us what we're talking about. It's important to wash your hands anytime you're going to do hand expression, which mom has already done, and then start simply by waking up your breast. And so we're going to see mom just going all around the breast with different techniques. She's going to do some rolling and some tapping. All of those are good to try because everybody's breasts respond differently to different stimulation. And the more things you try, the more you're going to learn what works for you. So after about 30 to 60 seconds of going around her breast, she's going to start the technique of pushing into the breast, so behind the nipple and then together. And so we're never on our nipple, because remember from some of our other videos, we talked about how the nerve that services the nipple is very sensitive to pain. So we want to always stay off the nipple and are into the chest wall. So you see mom pushing in and then together, and pushing in and then together. And you'll notice that actually she doesn't get colostrum right away. And then eventually you see the colostrum come. And colostrum can be any range of colors, green, even to a bit of a tinge of brown, because as breast tissue has been waking up, there might have been a little bit of blood. And so it doesn't mean you need to discard it. It just means that a whole range of colors are completely normal for your colostrum. It's important to wash. I apologize because I'm supposed to mute myself. So maybe you had feedback on that, and I apologize for that. Hopefully I'm not going to start the video again. Okay. So when you go to our website, which is where you can go to watch that video and a whole bunch of other videos we've put together that I'll talk to, you'll notice that we sell kits. And that, of course, when we're in breastfeeding work, can be very uncomfortable. And so I need to address the fact of why we sell kits. We needed to make the right thing the easiest thing to do. And sometimes for practices to put together their own kits, it is more simple to buy them from us with all of the things in them that we find helpful. So we do sell kits at cost recovery to clinics and to families who may not have access across Canada. We do it at all cost recovery, and anything that we do goes back into our work. So just recently we translated some of our key videos into Ukrainian because there's just really not as much access to lactation consultants there. So this is Dr. Prolius. He is my co-conspirator in More Milk Sooner. He is a gifted surgeon and obstetrician who has changed women's lives all across Canada. He practices up in Nunavut. We're now having to share him across Canada. He's been into BC practicing, and I'm always glad for the families and mothers that he's helping, but we always like to not always share him. He talks about this as literally, out of all of the things he's done, including some really pioneer surgery work, this will be the legacy that he leaves to his medical career. It will be the biggest impact he makes in helping women have an easier time starting and continuing to breastfeed their babies. And so coming from an obstetrician like him, who was the head of obstetrics for our province, that mimics how I feel about this work. There is no more important work than this because it sets women up to have an easier first month. So we're talking about colostrum. Interestingly, colostrum is started to produce in the body at 16 weeks gestation, before babies can survive even outside of the uterus. A Google search on this is really awful because at that early in the pregnancy, even Google's not really aware that breasts can be leaking colostrum. And so sometimes it tells women, oh, if your breasts are leaking, you might have cancer or things like that. But actually, when you think about development, always breast tissue is developing before ability to sustain life. So when a girl goes into puberty, first it's breast development, then period. And in pregnancy, we're already talking about how we're going to feed this baby before baby can even survive outside the uterus. I have now begun to refer to colostrum as baby, not only first food, but medicine for birth. And why that is because it allows our babies to have more stable blood sugars as they come into this world. There is nothing on earth that we manufacture that can match colostrum for stabilizing blood sugars. It also allows for transfer of maternal antibodies. So it really is baby's first vaccination. Anything that moms have come into contact with in their home environment, in their community, they're already in that third trimester making antibodies that are going to be transferred to baby to give them a head start with colostrum. So even if baby only receives colostrum, their immune system is going to function the higher for the rest of their life. So it really is the gift that keeps on going, and any amount of colostrum is a gift to babies. I have a real passion for the fact that it decreases inflammation. we know that our babies get here significantly safer than they did many years ago, but sometimes they have very difficult journeys getting here. And so the fact that colostrum is such a powerful anti-inflammatory can help with some of that transition stress. Decreased risk of jaundice, that is because colostrum is a powerful bowel stimulant. And when babies are having the stress reaction of jaundice in their bodies, we have to get rid of the risk of jaundice by peeing and pooping it out. So when we're giving babies this colostrum, we're allowing them to poop out colostrum. And we used to say in our hospital that it was normal for baby not to have a stool the whole first 24 hours. And now babies that are getting all of this colostrum, they're having 6, 8 stools and hardly needing to ever be retested for jaundice risk. And they're having an easier time learning to breastfeed because always when there is a reward for what is supposed to happen, we're all better learners. Okay. I love breastfeeding. It's so neat because it changes based on baby's needs. It boosts immunity and allows for food security. And we are blessed to have put together a really curated website that has not only videos for families, but videos for healthcare providers. We sat Dr. Prolius down and interviewed him on ways he uses this in his practice. And I just had feedback from a nurse who was starting in Calgary L&D, and they show Dr. Prolius and I's importance of the first hour video at orientation there. So it's really nice because sometimes providers need to hear it from a provider, and our most viewed video is the contraindications video with Dr. Prolius, which makes sense. We have started hosting a prenatal breastfeeding class at More Milk Sooner, which is actually, we can all thank Margaret for that, because I was working with Margaret a year ago, 18 months ago, and to do some presentation for the Breastfeeding Committee of Canada. And there kept being all these parents show up. And I was just like, why are there parents coming to this presentation? And it occurred to me that parents, I thought all of our work was done when we put it all out on YouTube. But what parents are looking for is connection and compassion from other people with knowledge. And so I trialed a prenatal breastfeeding class, and they have been extremely successful. We have a lot of early adopters in Ontario who are sending their families to it. And a quarter of everyone who comes to prenatal breastfeeding class at More Milk Sooner is from Ontario. So we personally have sent out over 32,000 kits to families around Canada since 2020. All of our videos are downloaded to our children's hospitals. And so our laboring nurses are always like, if mom has a bit of time, they make them watch one video an hour so that they just hopefully have a little bit easier time. And we want to thank our volunteers. We have amazing volunteers that make our kits that keep the costs at a reasonable level. So first hour hand expression. So literally using our hands or a really good breastfeeding baby. So it should be really say first hour breast stimulation from our hands or a really actively breastfeeding baby. What that does is it allows the brain to celebrate the success of this baby that has survived delivery. Our bodies are made for feedback to be received from the environment. So I always say at prenatal class, I'm like, if I was in a car accident, I don't have to think I need to raise my blood pressure and my heart rate and do all these things. Anything that's about staying alive is at brainstem level. And brainstem, which is at the back of our head here, is below conscious level, which is right behind our forehead. And so conscious levels is thought, and we don't have to think about things that are about keeping us alive. And how milk plays into that is that if there is breast stimulation to the brainstem within 1 hour of placental delivery, the body goes, oh, good, the baby's made it. We need to prioritize milk production. If in 1 hour there hasn't been really good breast stimulation, the brainstem says, unfortunately, this baby didn't make it. But because we are always managing resources, we're going to divert resources towards making sure that mom survives, and milk will come in later, because we all know that milk comes in anytime a placenta is delivered. But if there's not that feedback in that first hour, it's going to come in much later. So 100 years ago, We actually have a museum here in Saskatoon where they've brought in buildings from 100 years ago and put them all into, we call it 1920s boomtown. And one of the 1920s buildings that they brought in was a funeral parlor. And I was at the museum with my kids, and I was in the funeral parlor. And there was actually a infant loss memorial. And in that, it was talking about how infant loss is something that women across all of our generations in history have dealt with. And one of the perspectives they were sharing was that of a doctor who attended births 100 years ago. And what he said is that basically it was so common for him to have to bring a baby who hadn't survived delivery out of the home that he would take a purposely empty doctor's bag to delivery. And that is what we know in research. We know in the Middle Ages that it was high as 1 in 2 moms or babies did not survive delivery. So fast forward 100 years, it's much safer to have our babies. Thanks to the brilliance of obstetric teams across Canada, it is much safer to have babies. But a lot of the things that we do to get babies here safely sometimes make them too tired to be the only ones doing breast stimulation. And the other thing is sometimes it creates separations. And the goal is a healthy mom, healthy baby. Sometimes that is not able to also incorporate first hour breast stimulation. And so when parents are already aware of the importance of the first hour, then they can make sure that that happens and tell their body, even if baby's not here, don't worry about it. Baby's here, even if they're not. And we're going to go ahead and make lots of milk. So this study was done with families whose babies all had to go to the NICU. And so they split family. Nobody got skin to skin. Nobody got to hold their babies. Their babies all had to go to NICU. And the families were split into 2 groups. And the first families did hand expression within the first hour of placental delivery. And the second did hand expression in the second hour after placental delivery. And what you'll notice is that 4.19 mils of colostrum was expressed on the first time moms did it within the first hour. The interesting thing is that one of the really cool things that we do with this is oral immune therapy in the NICU population, where we're even giving as little as 0.2 of a mil every couple hours in the cheek in mucous membranes to help babies have an easier time and get some of those immune benefits. So you can imagine taking your 5 mils of colostrum up to the NICU and how exciting that would be. Our neonatologists in the NICU, every time we have a baby who's a little closer to term and just maybe needing some transition help, they're asking, does this baby come with their own colostrum? Does this baby come with their own colostrum? Because what we find is that inflammation is mediated and their stays are shorter. And they followed these mums for another 6 weeks. And what they found is that the mothers who had done hand expression within an hour after birth had measurable milk on day 1, and at 6 weeks had 130% more milk than the group who had done it in the second hour. And what I want to draw your attention to is the 2nd to 6th hour group is the purple group. And they had no measurable amount of volume collected until day 3. And that's when actually physiologically mom would be stable if she'd lost her baby to then bring milk in. So that's why milk stays off a little bit longer if there isn't that breast stimulation. So we know that we can't always control what happens in the first hour after birth. So when possible, we must move into the prenatal period. Moving into the prenatal period does several things. The first thing is it gives you a skill to learn in the comfort of your own home, with your partner, and actually have some communication as to what your feeding plan is going to do. Our families come to us very concerned about how baby is going to get out. That is primarily the biggest concern in the prenatal period. This gives them an opportunity to talk about feeding, and they come to the unit with a plan. And our nurses are so passionate about this because they know when women have done prenatal hand expression, they've had ideas, thoughts, and time to think about that outside of the hospital. So gaining a skill in the prenatal period, super important. I always say birth is like a marathon, and we do not meet people on the marathon finish line and say, now you're going to learn a new skill, and they're exhausted. We don't want to add a new skill to that first hour after delivery. So when we have that skill already on hand, we're golden. The second thing it does is sometimes we're able to collect a little bit of colostrum, which if we need it, can really be a protective factor for mom's comfort and for baby's needs. Some of the biggest advocates of this work are the support people who there's just an unforeseen maternal infant separation and they're given baby and they're put skin to skin, and it can be a very scary time where if they have their partner's frozen colostrum and their job is to give that colostrum in the first hour because we've got to get that medicine into baby, they have a job and they have a meaningful way to contribute to the wellness of their family. And they are sometimes the biggest advocates of this work. The third thing that it does is it seems to have protective factors that if things don't work out in that first hour, we don't have disastrous milk supply issues. So the very first woman that I met who had done this was before we were even suggesting it. And she had a 36-hour trial of labor, failed induction, and emergency C-section under general anesthetic, hadn't held her baby for 36 hours or for 18 hours after baby, first time baby, like just everything was stacked against this woman to not have adequate milk supply. I'm at the hospital at 36 hours and she's hand expressing transitional milk. And I'm like, what the heck? I mean, we were using a specimen cup because we didn't even know what was going on. And so all my colleagues are like, we've never seen this before. We've never seen this. And so I go in and I ask the mom, I was like, you're really good at hand expressing. Like, how did you get so good at this? And she's like, well, funny you should ask, because my biggest fear was that I wouldn't have enough milk. And so for the last month, I've been hand expressing in the shower to check that my milk is there. And so doing prenatal hand expression without even just intuitively knowing it in her heart. So is it safe? We have a whole conversation with Dr. Proyas in video. We also have a really solid research reference list on the website. So I will defer to those, but I will give you two perspectives from history. Gestational diabetics have been doing this for absolutely years because they are at risk for having babies who need support with their blood sugars, and diabetes. Insulin has a role to play in milk coming in, which makes those moms a little bit at risk for their milk coming in a little bit later. And what they have always said is that throughout history, we have breastfed our first baby through our second pregnancy as a form of food security. We've never had the food security that we have now. And moms always breastfed through the second one, and extended breastfeeding. We know from our First Nations mothers, it was just part of culture. And so if extended breastfeeding through subsequent pregnancies was safe, why wouldn't doing some hand expression be safe? Another group that really supports this work is if women who've had reductions, who have had breast surgeries, who have just PCOS, reasons to believe that they may struggle with supply. And their perspective on it is that, of course, the concern would be, are we going to cause any harm? And oxytocin is the hormone associated with milk and all of that. And so they always say that if a woman is cleared to have sex, she should be cleared to do hand expression because there's a heck of a lot more oxytocin in an orgasm. And so just to remind us that our bodies are always full of hormones, and we are beautiful beings, and even a pleasurable bite of food can cause a surge in oxytocin. And actually, we're kind of almost flipping the script with that, because there is favorable cervical changes that happen that give women potentially a better, easier time having spontaneous vaginal delivery. That's really emerging research. In India, they're already using it in parts of the rural communities that don't have access to C-sections to give women a better chance of having a spontaneous vaginal delivery. So we're almost flipping that script. But from a baby health perspective, in 2017, the Dane study, which was the Australia Breastfeeding Committee, sponsored a very big randomized controlled trial study to go. They took all of their gestational mothers, 912 of them, and measured baby and mom and made sure there was no adverse effects to say that it was safe with our gestational, low risk gestational diabetic moms. And so what we were kind of, I think, able to do in Saskatchewan is, because we're so close knit, because we have such a small population, Dr. Proyas had the brilliance of, like, if this is safe for our gestational diabetics, it is safe for our regular low risk mothers who have fear of not having enough milk. And so he was able to inspire the medical community, and our moms inspired the mom community. So it was like wildfire, and it is so normal here that actually now nurses are sad when moms don't come with colostrum. So we talk about it all across the care continuum, and we look at it as an insurance policy. We hope that the moms who collect colostrum do not need to use it, and we throw out an insane amount of colostrum from moms who have brought it to the hospital. It has, and they forgot to take it home because the breastfeeding is going beautifully. And so it is an insurance policy. We hope that you don't need to use your colostrum, but you have insured yourself against problems in the first hour, and should baby need a little bit of extra fluid. So this is what our colostrum collectors look like. And we really believe in the value of standardized kits. The last thing we needed in Saskatchewan was one person saying one thing and one person saying another thing. And so standardizing it, as well as giving people the tools to be successful, was important. Our study is hopefully being published soon. I had no idea that. I thought when we collected all of our people for our study, we were already halfway there, but it seems like it's 60% of the work happens with submitting to publications afterwards. But Dr. Perlius came to know very quickly that we needed to do a randomized controlled trial to test this in our hospital. And so what we did is we collected 167 mothers who did prenatal hand expression for 10 days and 170 who didn't, and compared their 24-hour sorry, that's my puppy. He comes to all of, and he's not a puppy, he's an old man, and he's having a little coughing fit, but he comes to all of my meetings. So Copper, the support dog. So we collected these mothers as they came to the hospital, if they'd done hand expression for 10 days or had not done hand expression, and compared their 24-hour and their 2-month exclusivity rates. And we had very, very amazing results that I can't wait to share. So we will publish that on the website when it gets into print, as well as we will share it on our social media. But it was nothing that surprised us, but it was very, we put our money where our mouth is what I say with that. So I am available to present to we have done grand rounds a lot of places in your province. I am available to meet with groups of nurses. I did a lot with Chatham as they were getting up and running. And it's just like this is my work. So I'm going to stop sharing there, and thank you all for coming today, and I will be hanging around for questions. So I will pass the baton back to.
Thank you very much, Nita, for sharing all the amazing work that you and your team have done to help families and healthcare providers. It's exciting to see all the research that supports antenatal hand expression. Next, we have Lauren Gertl, here to share her experience from a parent's perspective. Lauren is a first-time mother, an RN who works at a level 3 NICU. She had an uncomplicated and low-risk pregnancy. However, she knew from personal and work experience that antenatal insurance milk was something that she wanted to collect if able. She began antenatal hand expression at 36 weeks gestation, and she is very glad she did. Let's learn more about Lauren.
Thank you, Julie. So yes, that was a wonderful introduction. Yes, my name is Lauren Guthrow, and I'm really happy. Thank you for having me here today. I'm happy to share my story. So just bear with me here for a second. So yeah, this is my journey with antenatal hand expression. So yes, I'm a first-time mom, and in the context of this presentation, that's the lens I'm coming at with this. But I mean, my life is also influenced by my experiences, and I am a registered nurse, and I have worked in a NICU for the last 3 years. So to be honest, when I became pregnant, my thoughts and my normal for babies was kind of abnormal. What I saw was babies who were separated from their mothers, very, very preterm babies, as low as 22 weeks gestation. And I did see, you know, firsthand how Nada was mentioning, but I would say this to my patients, how breast milk is like life-saving medicine for babies. And mothers come into the NICU and, we would always say, it might take 3 days for your milk to come in, but secretly you always just wish it was there sooner because you just want to give it to that baby so much sooner. So that's just my background. Growing up, my mother is also a nurse and actually a lactation consultant. And I was just sort of bathed in this idea of upstream thinking, learning about how breast milk can help, with health issues or just set babies up for success into adulthood. My grandmother is also sort of an upstream thinker. She used to always say to me, as a saying, an ounce of prevention is worth a pound of cure, which I just love. And so in my personal and professional life, this idea of upstream thinking of doing things that can prevent problems in the future is just something that I've really latched to as a person. So I was pretty on board with the idea of antenatal hand expression when I learned about it. That being said, I didn't really know a lot about antenatal hand expression when I became pregnant. I first heard about it through word of mouth, my mother mentioning it to me as a lactation consultant, and also a patient when I was a nurse in the NICU came in with breast milk, a bit of colostrum, and I said, "How did you get this?" And she goes, "Oh, I used the HACA. I was expressing beforehand," and I didn't even know that was possible. I kind of thought, really, like, where'd this milk come from? But anyway, that was my very first experience. I also attended a More Milk Sooner presentation by NADA, actually through the BCC. So it was more geared towards healthcare professionals. But I was pretty convinced after that lovely presentation that this was something I wanted to try to do. And I should also mention it was brought up in a prenatal course that I took as something that people could do, but I would say there wasn't really much information other than it was something you could do. It was very just kind of skimmed over, or just not skimmed, but just mentioned, not really gone into detail. But I thought it was neat that they mentioned it. So exclusive breastfeeding was something very important to me just through my personal and work experiences. The More Milk Sooner presentation really hit home that the first hour after delivery, it's important to stimulate your breast. And I just so saw that as a nurse. We often would say in the first 2 hours, you need to start expressing milk, but this first hour was just kind of eye-opening to me. And I felt like it was something important I wanted to work into my plan of delivery if something were to go wrong. So I wanted to again, collect that insurance breast milk in case something didn't go according to plan. I really had to work during my pregnancy to normalize birth and stay in a frame of mind that everything was going to be normal, and just because of my work experiences. So that was what I was working to do as a pregnant first-time mom. And the idea of having insurance breast milk was kind of nice to me, because not so much of that I was worried if my milk would come in or not, more because I thought about these scenarios of what if me and the baby were separated? How could I have milk available for my baby if that were to happen? Hoping it won't, but if in case it did, I thought it was reassuring to me to know that maybe I could have that milk. So my plan moving forward, once I decided that for myself, was to have everyone on the same page. So I wanted my birth support team, which was my husband and my mother, to know that I was doing antenatal hand expression, and that the milk, where it was in the freezer, here's where it is. And I also wanted my midwifery care team to know that that I would have this milk available, and that hand expression in the first hour, if I was separated from the baby, was something that I wanted to do. And I just want to mention on that point, when I did mention that to my midwifery care team, they said something kind of like, "Well, won't you just breastfeed?" And I thought, oh, they don't really get what I'm getting at. I think just because in healthcare, sometimes we're so siloed, you know, their brain wasn't going to the what if separation piece, I think. And not that that's bad. They were just thinking normal, which is fine. That's what I wanted. But it was just interesting to me. I just think about how sometimes the disconnection is there within healthcare. But anyway, I told them what I wanted, and everyone on my team knew. So we were all on the same page by the end of my pregnancy. So here's how it went. I started my antenatal hand expression at 36 weeks. So I kept track of it, just for my own curiosity's sake. So the first attempts were just done in the shower, sort of as suggested, in the more milk sooner. And I did get milk. Um, I was lucky enough to get some colostrum, and I actually got a fair bit of colostrum. Um, as time went on. I feel like I was pretty happy with it. One thing that I took away was it wasn't as easy as I thought it would be. As a nurse, I would teach people about hand expression, but obviously I had never done it myself. And I remember thinking, like, how is anyone supposed to do this? Like, I'm trying to get the milk out and it's leaking or it's spraying or whatever, or I was doing it too hard. It definitely was a skill that needed to be practiced over time. And I'm glad I had the experience of doing it, because now I have a different viewpoint on how it can be kind of difficult to do, and it takes time to learn. So I was just collecting very little amounts at first, like 0.3 mils. Eventually, I kind of worked up that on average, I would get maybe 2 to 3 mils at a time. But because I was getting uh, volumes larger than 1 mil. The syringes I had originally acquired were only 1 mil syringes, and now I realized I needed maybe a 3 mil syringe, which was sort of hard to find. I forget why I was having a trouble. Maybe I was being picky where I got them from. I don't know, but I ended up going to a pharmacy and finding some 3 mil syringes. And also, I also ended up expressing into a clean shot glass, which was just easiest for me because I found I was losing a lot of milk just from spray. When I was trying to collect. So that was my collection journey. And the largest volume I ever got was actually the night I went into labor on April 16th. A few hours before my water broke, I got 8 mils. So I had no signs of labor at this point. Like, I was just doing some hand expression, and that was my largest amount. I'm curious why that was, but anyway, maybe it was a sign of things to come. So this is just some pictures of my results. So the 0.3 mils was sort of at the beginning there, and then moving on to my sort of almost 8 mils that I got the night I went into labor. And in total, I think I collected about 40 mils of colostrum or breast milk before I gave birth. So I'm going to talk about my birth story quickly. This is the last photo I took before I went into labor. It was only a few hours before my water broke, and my last thing to do was to get my hair done. And I managed to get it done. And the girls were joking I'd have the best hospital hair if I went into labor that night. Little did we know I actually did go into labor that night, but I did not look decent afterwards. So this is the last decent photo I have before I gave birth. So my water broke at 10 p.m. that night. I was just over 39 weeks. I had no signs of labor before my water broke, and things moved pretty quickly, and it was intense right from the start. Um, I'm an upstream thinker, but I forgot to put gas in my car when we were trying to get to the hospital. Thank God for my mother. She was with me and she filled it up very quickly, and we continued on our way to the hospital. So we got to the hospital, and I got to the stage of needing to push pretty quickly. So I was hoping to have a natural birth anyway, but I remember being in the hospital thinking an epidural might be nice actually, but I knew that it was just too intense and I wouldn't be able to lie still. So it never happened. Um, the the pushing came quick, but the pushing was long. I pushed for over 3 hours, and when baby came out, we realized it was maybe so difficult because he was actually sunny side up. So that explained a few things to us why that took so long. But I did have him vaginally. Um, and I remember thinking, okay, well, I didn't have an epidural, and people say when they have births like this, they feel great after, like baby comes out, and now I feel amazing. Not so for me. I, for some reason, had pain, quite a lot of pain right after the baby came out, and that continued on for quite a few days. I had what I found out was after pains. I didn't know they existed. I felt a little annoyed. No one warned me about this in prenatal or the midwives or anyone. And I found out that's usually because it's sort of uncommon in your first birth that would happen. So I was a little taken aback by that. Um, because of these after pains and because I was so exhausted from pushing for so long, I had no energy to latch my baby. He came out actually quite vigorous, but I could not latch him myself. My mother, thankfully, did that for me. She was helping the baby latch. And if I didn't have someone there who knew that was important and what we wanted, I don't know that would have necessarily happened. My midwives were pretty busy dealing with other things. But this support person I had who knew what I wanted helped the baby latch within that first hour. And then we were home by 10 a.m. I didn't want to stay in the hospital. I wanted to go home. So we did. And so overall, I got pretty much everything I wanted on my wish list for my birth. So why the milk mattered to me. Post-delivery, these afterbirth pains continued for probably honestly, a week, but I mean, really intense in the first few days. I had like 9 out of 10 pain with every breastfeed. So when I'd start breastfeeding the baby and they're firstborn, I mean, I know they're just meant to suckle for a long time, but I would just be in such pain. I did have to occasionally stop and say to someone, can you please take the baby? Because it was triggering these contractions. And in those moments, that's when we would use the collected colostrum to give to my baby when I wasn't able to continue feeding him. He also was born because it was such a long time pushing with quite a large swelling on his head and bruising. And subsequently, he did have sort of higher level bilirubin and did have jaundice. He was quite a yellowy color when he first came out for the first few days. So I knew that the breast milk could help get rid of that bilirubin in his system. And so I was really, after every breastfeed, even giving him extra colostrum with the syringes just to try to help get him to poop more, because I was hoping that we could avoid phototherapy. I really did not want to have to go back to the hospital if I didn't have to. And he was stooling. I don't remember how much he stooled, but he definitely did. And the benefits for me was really just peace of mind. I mean, we were home. I was having pain. I was having difficulty having him stay latched for a long period of time, but I knew I had this milk. And in the photo, you can see here my mother holding my son. You can actually see the syringes of colostrum beside her on the table there that she was helping me give to him in the first few days. So he always remained below phototherapy levels. And he also just had minimal weight loss. He was, I think the max weight loss I have there, it was, we calculated 4.6% in the first, that was the max weight loss he had. So reflecting back, that support with latching the first hour was really pivotal for me. Like I said, you're just in a whole other world when you give birth, and having other people know that that's what needed to happen. I don't know if I guess I would have remembered, but I was just so exhausted. It's hard to have that all on the mother. Um, so I was really glad someone was there who knew what I needed in that moment and what my son needed. The afterbirth pain while breastfeeding. So as you know, now that I've had my baby and I've had time to think back, I think, I don't know that this would happen, but I could see it just as a person who works in healthcare, that if I was having intense pain and perhaps I was, admitted and there wasn't anyone there who knew what I wanted, maybe they would have said, oh, well, you're having a lot of pain. Why don't you just give a bottle right now and just let the baby feed that way? I could just see that happening. Again, I'm not saying it would have, but I think that's a moment where that could have happened, but I had my colostrum, and so it wouldn't have needed to happen. And then no worries. So really, we were equipped with colostrum. I had everyone on the same page about what I wanted, and so these things that maybe would have been issues of I can't keep my baby to the breast, it didn't feel like an issue at the time because I had this milk that I just knew was there in the back of my brain. It never actually even felt like an issue. And when I was approached about maybe even talking about my experiences, I thought, well, what is there to talk about? I don't really feel like that anything that exciting happened to us, because it didn't feel like a struggle when you have the proper supports around you and the things you need when you need it. So it was a nice, calm transition to becoming a mother and my baby being with me. So I just think back to that quote I said before, an ounce of prevention is worth a pound of cure. I'm thinking back to my grandmother, and her mother used to say this, and really in milk, it actually is an ounce of milk that I got a little bit more than, and it just resonates with me. And I'm just going to check my notes and make sure I caught everything I wanted to say here. But Yeah, I just want to say thank you so much for letting me share my story. My son, breastfeeding was successful in the end. We exclusively breastfed. He's still breastfeeding. He's 13 months old now, and we're planning to continue. And thank you so much.
Thank you, Lauren, for sharing this important parent perspective. It's so important to understand how antenatal hand expression can impact a parent and a baby. Our next speaker is Emily Fung, here to tell us about the experience of implementing antenatal hand expression in a hospital setting. Emily is a clinical nurse specialist in the Women's and Infants Health Program at Mount Sinai Hospital, where she has been directly supporting the Mother-Baby program since 2021. Prior to this role, she worked for 4 years as a registered nurse on a high-risk antenatal unit. Emily currently serves as a co-chair for the Baby Friendly Initiative Committee and actively contributes to several infant feeding quality improvement initiatives across the program and hospital. In addition to her work at Mount Sinai, she practiced as a casual nurse at the Sexual Assault Domestic Violence Care Center at Women's College Hospital. Emily is deeply passionate about perinatal health care and is committed to advancing education and delivering high-quality, compassionate care. Thank you.
Thank you so much. As Julie introduced, my name is Emily Fung, and I'm so grateful to be part of this antenatal hand expression awareness event today. During my talk, I'm going to really give an overview of how implementation worked at my hospital at an acute care center. So some of the objectives here is really focusing on each step of the way that contributed to the success of the implementation of antenatal hand expression in the hospital setting, which we'll dive into each of these topics. And at the end, I will share a summary of my key findings and recommendations that perhaps you and your area can take forward during your implementation time. The first overview really is to develop a working group and a committee, and this can help to have some buy-in from all the different health disciplines in your area. At our hospital, we do have a large women's and infants health program, which is really amazing because we have so many different health disciplines that are contributing to and committed to supporting infant feeding through our Baby Friendly Initiative Committee at Mount Sinai. During our committee meetings, we also identify various different working groups that different staff members can participate in or lead and join. So one of the working groups that we developed back in 2021 was actually focusing on antenatal hand expression. So some of those ideas initially that we thought about was making sure that there was information on our website, creating a pamphlet, creating a guideline, having supplies available, and possibly including the antenatal hand expression practice as part of some of our clinical nurse specialist care plans. As a clinical nurse specialist, we get consults to see patients with a bit more complex history. And in this case, we wanted to have consults for patients who were interested in antenatal hand expression and also who were eligible. As a high-risk center, we do have a number of patients who we maybe would not recommend starting antenatal hand expression with that risk, very small risk of preterm labor, and as Naida had reviewed from the literature. So I think developing a committee and a working group really is going to be the basis of your planning and implementation, especially having those different disciplines involved. In our antenatal hand expression working group, you can see we did have different practitioners from family practice, actually a midwife nurse, from prenatal education. So one of the prenatal education coordinators who's here today, Suji, again, who helped to really ensure that that education was also implemented in all the prenatal classes that the patients attend and join. As the leads, it was myself and my colleague and fellow CNS and Natalie. But part of the evolving working group, eventually, we did have nurse practitioners, obstetricians, pediatricians, dietitians, as well as social workers, and our communications team too. With the development of our hospital policy, this really helped to outline all of the steps involved with antenatal hand expression from the staff side as well as from the patient side. So with this development, we were able to develop a patient inclusion and exclusion criteria, as I discussed, as with our high-risk population and a low-risk population. We were able to determine some of those criteria based on their pregnancy risk factors, which might include, for example, placenta previa, invasive placentas that we would really try to avoid having them go into preterm labor. And then other patient areas would be individually considered, and making sure that we would review that with the primary care providers involved in that patient's care. Part of the policy helped to dictate the procedure of antenatal hand expression. So including, hopefully, most patients are coming through our prenatal or ambulatory care setting from our clinics. So having a process where it's introduced and at what gestational age are we starting that conversation. So part of the Ontario perinatal health record in a prenatal setting, there is a question to ask patients, typically in their second trimester, their intention for infant feeding. So part of that, we also wanted to loop into the nurse's routine care. So again, we're not adding a new extra burden onto their practice, but involving and just seamlessly integrating that into their routine assessment of adding on, have you heard about antenatal hand expression? Would you like to know more? So part of that, we were able to select and identify patients who were interested so that we could start a smaller population when we first developed the policy to do the education and implementation. We also determined what that would look like for patients at home for collection and for storage. So we'll dive a little bit deeper into that shortly, but making sure that part of the policy that the staff know exactly how to educate patients on doing antenatal hand expression at home, and how to transport that to the hospital when it's time for their delivery, whether they're going into spontaneous labor or whether they had a planned induction or C-section date, for example. We wanted to make sure that there was standardized practice on how to safely and according to our IPAC rules as well, our infection control guidance, to make sure that we had some standards for patients to follow so that, again, all of that colostrum that was collected was safely stored and transported and nothing was going to waste. Part of the admission to the hospital process, we did give some guidance again to make sure that there's some guidance to the staff and expectation for the patients on what that storage procedure looks like. Currently at Mount Sinai Hospital, we do have a human milk fridge in every unit. So one in each unit's medication room. So on labor and delivery, on our antenatal unit, on our postpartum or mother-baby unit, as well as in our NICU, we actually have a dedicated milk fridge to each baby in their own individual rooms. So making sure that everybody was aware of that process and how to store that with the labeling and identifying process on admission with the patient hospital labels. We also identified a bit of guidance for thawing the colostrum and what that looks like, especially, with patients who are coming in for induction or in spontaneous labor. you never know when they're actually going to deliver and when we can actually use that colostrum. So we wouldn't want to, take it out too early ahead of time, where the milk is going to, come to room temperature too soon and maybe go to waste, or taking too much time to thaw where it might still be frozen and not readily available after birth. So giving some guidance around that as well to make sure, again, it's safe and follows our infection control practices. For the indications for use, ideally, a lot of these patients who are doing antenatal hand expression are hoping to provide their human milk. So whether that be also in conjunction with breast chest feeding, with pumping, or hand expressing after birth, we wanted to make sure we're supporting their primary feeding goal. In addition, having, like Lauren was saying, this insurance milk on the back of their pocket. So whether that be, initially starting the breast chest feeding journey and having the latch go, and then topping up with the collected colostrum as a supplementation, or again, for those parents or babies who are having hypoglycemia monitoring or the protocol, that we, instead of going right to formula for supplementation, that we are able to use their collected colostrum as supplementation for that reason as well. So a bit of guidance and different variations of indications for use. For the administration of the colostrum, we don't support syringe feeding in the hospital, although that is the collection method that we're teaching parents to do at home, especially when it's smaller volumes, that we make sure we're kind of decanting essentially from the syringe into different formats. So whether that be into a little medicine cup, into a spoon, directly on the patient's breast or chest at their nipple. So again, that baby can suckle the drops from the chest, or onto their finger, into a feeding, if there's enough volume, into a bottle with a nipple as well. So again, different ways to administer the colostrum safely, and again, not directly from the syringe, so that it can be baby-led. Upon discharge, we of course made sure to have some guidance on what that process looks like. So whenever we're transferring between units, we're also doing those double patient identifiers and transporting the collected colostrum between the unit milk fridges. So nothing gets lost. We're making sure it's all labeled correctly with the date and time of expression. And then on discharge, making sure that we're documenting that the patient is going home with a collected colostrum syringes, and double checking that if there are any syringes left over. We have had scenarios where patients have forgotten, or the nurse has forgotten, and calling the patients back in a timely manner, doing frequent milk fridge checks as well. So usually our charge nurse or one of the nurses will support that on their daily kind of equipment check shifts. And so hopefully that we can make sure that nothing ever goes to waste. Part of the education and spreading of awareness, we were able to add antenatal hand expression section to our Sinai Health website. This is actually a new revamped version of our website from last year. So really making sure that all the information is easily accessible to your patients and your families, I think is really huge. And also for even staff to give guidance to, hey, here's a website, let's just teach from there. Here are all those topics, and then you can get more information. So again, they don't have to memorize every single detail, although of course, eventually, now we're at that stage where it is normalized into their everyday practice and into their everyday knowledge. But at the beginning, we wanted to, again, make it seamlessly easy as possible for everyone to adopt and spread the awareness. So I think if you have ability and access to adding your resources and information to different formats, whether it be printed or electronic, like on your organization's website, I think that's a really helpful point. And of course, utilizing that as a teaching tool for your staff and patients. In addition to the education that we provided verbally, we also developed a healthcare provider guide. And this really just gives a nice snippet of summary outside of the policy where it's a bit more detailed. So it's a bit of a snapshot about the healthcare provider's role in antenatal hand expression, why it's important, and some safety and considerations for risk factors. Understanding those benefits for parents and for the babies, understanding where and what our colostrum collection kit involves, and I'll go into that a bit later as well. And then what that process, again, snapshot looks like in bullet points in the hospital when the parents are coming back, how much to bring, how to store it, how to transport it, what is the feeding guidance or indications, and making sure that this was a nice, easy tool for all of our staff, not only nursing, but including our lactation consultants, our OBs, our midwives, and that everyone was comfortable with understanding the information and how they can support antenatal hand expression for patients. On the patient side for education, we also developed a patient brochure. And again, more detailed information on our website, but a lot of the condensed information is on this brochure. So this could be easily handed out with the routine prenatal appointments when they're getting all of their information at those different times in their trimesters. This is a really helpful tool for patients to take it home, read through it, mull on it, and then come back with any questions or concerns the next time they return to clinic or to the hospital. So this is available in our prenatal clinics as well as in our inpatient antenatal unit. So different, again, different areas where the exposure can be shared. On our patient brochure, this is just the back side. So I'll flip, this is the inside. So this is the first thing that patients would see. Again, going over similar to the healthcare provider guide, what antenatal hand expression is, why it's important, what is colostrum, and then benefits for parent and baby, how to do it in a step-by-step manner with a little diagram of the hand expression steps of press, compress, and relax. And we also did link the QR code to Naida's team, the More Milk Sooner website, to that amazing video that we briefly saw. So I think with that, in combination, sometimes some nurses or ourselves as a CNS team would be able to actually do some hands-on practice with the patients in clinic. So they're comfortable, they know exactly the technique, they're doing it properly. And again, at the end of the day, that stimulation is truly so key. Whereas I always try to set that expectation that maybe not everyone is going to be able to express or collect any colostrum. And that's okay, because our two goals are that early stimulation and hands-on practice for the parents so they feel comfortable after birth, how to hand express. And we know that hand expression is also the first steps to breast chest feeding or that initial latch. So I always try to stress that those are the two main goals. And it's a bonus to be able to express any colostrum and collect it. So not putting any pressure, normalizing that they might not see or be able to collect, even if it's very tiny amounts that they're able to express. It's okay if they can't collect it, because the important parts is the other two, the stimulation and the practice. However, on the back side of the patient brochure, we do have the collection and storage guidance there. And with that guidance, we do indicate for patients to only bring enough for a 24-hour period, roughly. So between 1 and 15 mils. Again, thinking about that delay in the time of being admitted to the hospital and then actually delivering baby. So sometimes it could be anywhere between 12 to 24 hours, let's say on average. So we don't want any of that milk to be wasted, as we're asking them to store it in their freezer at home. Which for the level 1 term baby is good for 6 months in the freezer. And then typically we say 6 days in the fridge. Oh no, someone is clicking. Sorry, I'll go back. Oh. Okay, sorry about that. So any colostrum that is being moved from the freezer storage to the fridge. So now in the hospital, we only have the milk fridges. So again, that's a change in that temperature control and a risk for introducing bacteria. So we make sure that from freezer to fridge that we're going to use that colostrum within 24 hours. And then from freezer to fridge to room temperature, again, we're giving guidance to our nurses and the patients that we want to use that colostrum within 1 hour for the infant ingestion. For any colostrum that has passed that safety guidance of timeline, we do inform our patients and nurses that they can actually still use it externally. So even if we're not identifying that it's safe for baby to ingest at that certain time, if it's past the 24-hour mark from freezer to fridge or past that 1 hour mark from freezer to fridge to room temperature, they can use it on their own. Oh, if someone could stop clicking. If they could use it on their own, nipples or any kind of cracked areas on their breasts, we know that colostrum has all those great antibodies so that it can support the healing with any cuts or concerns. And same goes for baby. So using that colostrum externally, if they have any scratches on their face, or eventually when they do have their first or their newborn bath at home or in the hospital, they can always mix the colostrum into their bath water. And of course, we also talked about making sure that we're still supporting their infant feeding goals. So if that's breast chest feeding, that's always going to be the primary. And these colostrums are always going to be an extra snack, a top up, or for backup. For any extra colostrum collected at home, we do advise patients that they can definitely use the colostrum in other ways. They could mix it later on into their milk at home if they're doing combination feed, or into their soft foods if they're starting soft foods later on at 5 to 6 months, for example. Or if they have an older child at home, again, they can mix that into their bath water or their foods as well. So again, different ways that they can utilize the extra colostrum that they've collected or any kind of past ingestion safety time of colostrum. And I know on the brochure it does say room temperature for 6 hours, but we do clarify that if they express fresh colostrum in the hospital, that can stay at room temp for 6 hours, and that's safe. It's just when we're changing that temperature from freezer to fridge to room temp, that's where we give the guidance for the use within 1 hour. For the thawing, we actually try to avoid, I know there's lots of, different techniques that people have used. In the past, we've heard about, putting it in a water bath, for example, or something like that. But really, ideally, we just let it either sit at room temp, and with the smaller syringes, of course, it should already thaw from freezer to the fridge and then to the room temp. It should only take a couple of minutes to kind of warm up. Or the nurse or the patients can definitely kind of roll the colostrum in between their hands to warm up, or just put it in their breast or chest or on their armpits using the body heat to warm up. So again, trying to minimize any risk for bacteria introduction. And also part of that is when they're transporting the colostrum to the hospital, we recommend putting it in a cooler bag that is with a freezer pack. So not a bag of ice cubes. Ice cubes can melt, and again, not regulating that temperature control during the transport very well, whereas the freezer pack is a bit more guaranteed for longer durations of transportation. For patients who live close, we recommend that they actually have someone bring it close sooner or closer to time of delivery if we can predict, or if they have support people available to do that. If they're from far though, and a lot of our patients are not from the GTA at Sinai, so again, making sure that we're limiting the amount that they bring so nothing goes to waste when they're bringing it. For the hand expression guidance, we are letting patients know that the frequency should be twice a day for 5 to 10 minutes at a time, alternating between both breast and chest tissues each session. We do recommend that they monitor for any abdominal cramping, uterine cramping, or contractions in between each session. So for example, I would tell my patient to do the session in the morning, And then monitor throughout the day. If they do get any cramping, take some Tylenol or rest, relax, whatever pain measures that they use, and then see if it goes away. If it's not an issue, go ahead and continue that nighttime session. If it persists and they're a little bit concerned, that's okay. Skip that nighttime one and try again the next day. And maybe instead of 10 minutes, you're doing 5 minutes. So we're limiting the amount of time so that we can minimize some of those side effects if the patient is feeling them. Out of like an average of 10 patients, let's say, I think about probably 4 out of 10 actually feel some sort of light abdominal or uterine cramping. So again, just to give a bit of, and from my experience anyways, the amount of patients who actually feel any side effects at all. Okay, so moving forward to the access and availability of resources, we were able to work with our Sinai shop, which is an independent business part of Mount Sinai, that to develop a colostrum collection kit. We know there's colostrum collection kits, on Amazon, on other websites. You can just get sterile syringes from the pharmacy or the store, as Lauren was mentioning as well. And a lot of times, sometimes when they're ordering their breast pump as well, it might come with some colostrum collectors. But we really wanted to make it simple, easy, and again, affordable and accessible for our patients and families. So we were able to develop a colostrum collection kit that had 2 sizes. So kit number 1 includes 5 1 ml syringes and 2 3 ml syringes, whereas kit number 2 includes 7 1 ml syringes. So again, depending on how much colostrum patients are actually able to express, that might determine which volume of syringes they're going to purchase. We also included in the kit a 30 ml collection cup. So it's just like a little medicine cup, just for ease of collection. So patients can express directly into the medicine cup and then draw it up with a syringe. As Lauren was saying, she used a shot glass, which is awesome, super, super helpful as well. So in that same thinking, we wanted to make sure that it was easy to do for patients and families. Some patients are a bit more advanced and like the video that Naida was showing, they could draw it up directly from their nipple as well using the syringe. But that's not always an easy technique, or if you don't have a support person there with you when you're doing your antenatal hand expression, it's a bit easier for them to just express directly into the medicine cup and then draw it up in the syringes afterwards. Part of the colostrum collection kit, we also include expressed milk labels. So they're sticker labels that we include with each colostrum collection kit package. So it has the name, date, and time fields for them to fill out. We always let them know to try to use the oldest colostrum first. So again, nothing goes to waste with all of those timelines we talked about. And this is especially helpful when they're bringing it into hospital, so the nurses can also help identify which colostrum syringes to use first, etc. For the accessibility, at first we were just selling through the Sinai shop, which we do have a physical location inside the hospital building. For those folks who don't know, at Mount Sinai, we do have a clinic building, which is 2 doors down from our actual hospital building. So all our prenatal clinics are actually at this separate building. So in light of that, we were able to actually have a storage of colostrum collection kits at our clinic building in one of our maternal disorders clinic. And recently, we also expanded to another low-risk OB, her office directly, because she is a huge advocate for antenatal hand expression and infant feeding. And she actually always promotes it with her patients. So she has quite a large population of patients who are interested and actually adopt antenatal hand expression. So again, she has some, and there's some in the maternal clinic. And then we also sell it at our Sinai shop on the 17th floor in the hospital building. During after hours, because the Sinai shop only operates during the daytime, we have made it accessible also 24 hours pickup in our mother-baby unit. So with our mother-baby unit, that is where our postpartum patients go. And there is a charge nurse and a ward clerk, or a unit clerk that is staffed 24/7. So again, having 24/7 access, and we developed this colostrum collection pickup kit. So like a little tracking tool where patients purchase the colostrum collection kit online, they receive an email with their invoice number, and then they take that invoice number email for the wherever they're going to clinic or to the mother baby unit, where they can then jot down the order number and we're able to provide them a kit right away. So they don't have to wait or walk back from clinic to the hospital to grab the kit. So again, making it accessible in different areas in different ways for your patients, I think is truly key in supporting this practice. Ideally, I think in the future, it's part of one of our BFI goals to make sure that we can actually find some funding to support giving the colostrum collection kits for free. I think that would be huge, again, on the ease of uptake for patients. So hopefully we can do that in the future as Naidi and her team does. With the education and practice, we utilize the BFI 10 steps for guidance, which we developed a kind of a varied version of our baby feeding timeline in assisting parents following their infant feeding progress during their hospital stay. So we adapted this poster from the Best Start website, which has the baby feeding timeline from birth to 48 hours. It outlines at each stage in the first 48 hours of life, how many feeds are expected, what things they can do, skin to skin, latch, hand express, their tummy volumes, wet and soiled diapers, expectations, and then some tips about getting help. So part of the Best Start is mainly the center part. And what we've done to adapt is actually added both sides on the right and the left side is the cues for feeding on the left, where it goes into early cues, mild cues, later cues, and the right side where we added skin to skin, how to latch, and how to hand express. So again, giving that guidance and reinforcing it in different ways throughout the pregnancy journey, as well as in different formats throughout the hospital setting, I think is really, again, helpful and important for that continuity of antenatal hand expression awareness and implementation. These posters are printed and available at each bedside, actually, of our postpartum unit. There are a few on our antenatal unit and also in labor and delivery in the labor rooms. We've also had a few posted in our clinic areas, again, just setting those expectations ahead of time. This poster is also available on our website. For the documentation, so again, supporting our nursing staff to make sure it wasn't something challenging or a new workload they had to adapt and a burden to their everyday practice. We really wanted to seamlessly integrate that into their workflow. So part of that is making sure that there are easy fields for hand expression documentation, not only for in the infant's chart, but also in the maternal chart, which I will show shortly. Part of this also adds to helping pull the data for data collection for when you're doing chart audits. So again, we can show what is the actual uptake of hand expression, how many people are actually bringing collected colostrum to the hospital. So in the maternal chart, as you can see, we do have a bunch of different indicators. A lot of them are from our born indicators, as well as BFI indicators and hospital indicators that we've developed. Born, for those who might not know, is the Better Outcome Registry Network, and they compile and compare data from all the birthing hospitals in our province of Ontario. So again, that's a great way that we were able to integrate antenatal hand expression to ongoing initiatives we already had going on. Diving into data collection. So luckily at Sinai, we do have an auditing and reporting team that helps on our back end of our electronic medical records, so our EMR system, to pull from all those fields that we've indicated for our hand expression data, to make sure that they're able to collect the data, pull it easily, right? Not adding on so much work to another team, another provider, and then generate these graphs for us to show that that we're really meeting over our benchmark targets. And again, those are those provincially set targets from BORN. As you can see, we've been doing pretty well since the start of antenatal hand expression implementation in 2021 to most recently in this graph is September 2024. There were a few times we had dipped below the benchmark back in 2022. And a lot of it, when you look back at those timeframes in healthcare, we were experiencing a large shortage in health human resources. So staffing challenges, nurses leaving the hospitals, finding travel nursing contract jobs, working outside in the community, in clinics and public health. So during that period, we did note a lot of our charting was condensed to meet those staffing shortage needs. So they would do a nursing status summary, let's say, or a text summary of the care they were providing versus going into each of those clicking, we call them iView, our bands to actually check off each item. So a lot of our data was actually missed because of those documentation gaps that was happening. And a lot of the times, we know the practice is happening, and sometimes it's just challenging to find the documentation field. It's challenging to find time to document that field. So we know that documentation gaps from the staff side also contributes to the ultimate data that you're able to collect. So really honing in documentation as part of your education, again, so key, and making sure that we're able to capture the actual picture of how we're doing in supporting patients to complete antenatal hand expression or hand expression in general. Other ways we were able to spread awareness was inviting, for example, Naida and her team to our obstetrics and gynecology grand rounds. And this was back last year, March 2024. It was a huge hit. Lots of people showed so much interest, and especially the obstetricians, adopting that and again, normalizing that into their prenatal care and their prenatal appointments with the patients, so that they're also bringing it up in addition to the nurse bringing it up, in addition to possibly patients being able to see it on our website, learn about it in our prenatal education classes. And of course, social media had a huge uptake and influence on this as well. But I think inviting, other care providers or presenting at different forums with different disciplines is super helpful to, again, the ultimate implementation of this practice. Other ways we spread awareness was highlighting patient stories. So during Breastfeeding Week, National Breastfeeding Week back in October last year, we were able to highlight 2 family stories. One on the left was a level 1 or term baby population, and then on the right was an NICU baby and family story. Through these patient stories, as we heard from Lauren, it's so motivating for care providers and for patients and families to hear really how impactful antenatal hand expression is to support their infant feeding goals and their ultimate journey, as well as the development and well-being of their newborns and their children. You might recognize I'm there on the left. I am biased, of course, because that patient was also my colleague who did amazing with her antenatal hand expression, collected tons of colostrum, and was able to successfully meet all her goals and having a good milk supply after delivery and supporting her baby boy, Soren, there to successfully continue to still breastfeed now at 18 months. Unfortunately, she wasn't able to join us today, but if you'd like to see her story, there is a video link again on our Sinai Health website that you can check out and watch. So key findings and recommendations, just again to summarize everything we've talked about today. Organizing a working group, having those multidisciplinary teams involved is so important to not only have buy-in, but really make sure that everybody in your program is on the same page and supporting the same goals of infant feeding, and specifically with the adoption of antenatal hand expression. So whether that be midwives, LCs, dietitians, educators, communications, working with our communications team to develop those Sinai Health news stories and highlight those patient experiences. All of those have such a big impact to really the ultimate goal of success of implementation. Demonstrating that ease for providers to adopt, so highlighting that it's minimal added work to the current practices, identifying opportunities to implement into their current workflows, like during the prenatal appointments, having the antenatal hand expression brochure incorporated into the prenatal booklets that are already happening, integrating into the curriculum for the prenatal education classes, making it a routine question for antenatal inpatient admissions. And of course, having availability of the posters and brochures in the clinics and in the hospital setting. And with that, creating that availability of access to resources and tools for your staff and your patients. So working with your hospital stores or shop to provide those colostrum collection kits if it's possible. Building in these auditing structures to share your data. Working with your IT or data or auditing teams and highlighting the importance of those BFI and born indicators. Again, showing how much work and success is going on really helps to continue and sustain this practice. Advertising your successes, so working to share those patient stories with your staff and with your community, collaborating with different nursing or medical rounds, spreading that awareness and education. And again, with that sustainability of practice, continue to highlight these practices and impacts over time, updating your policies and resources as new evidence comes to play, or as NIDA publishes their results, including that into your policies and your guidelines. For us, future directions that I'm thinking about now is continuing to expand those pickup locations of the colostrum collection kits, and expanding all of the OB clinics where the patient brochures are available, and into our midwife partners, et cetera, and different family practice teams that are involved with Sinai. Truly, at the end of the day, all of this does take a village. So thank you all for taking time to join us today to learn more about antenatal hand expression. I'm so proud and grateful to be part of this group and presenting our journey so far at Mount Sinai. If you have any questions, I'm always feel free to reach out. Happy to help and support this practice. Thank you.
Thank you so much, Emily, for giving us insight into what it has taken to implement antenatal hand expression as part of prenatal care in a hospital setting. Our next speakers are Donna Boyd and Tina Bogart, here to tell us about their experience of implementing antenatal hand expression in public health setting. With over 24 years of experience in public health, Donna is a dedicated healthcare leader currently serving as a program manager for the Healthy Growth and Development Program at the Chatham Kent Public Health. In this leadership role for the past 4 years, she has overseen programs that support the health and well-being of children and families, drawn on 2 decades of frontline experience as the health promotion specialist and public health nurse. Passionate about community care, she also volunteers with Hospice of Windsor and Essex County Incorporated, providing compassionate support to individuals and families during end-of-life transition. Her career reflects a deep connection to health equities, preventative care, and well-being across the lifespan. Tina is a registered nurse with the Chatham Kent Public Health Unit, specializing in the Healthy Growth and Development team. With over 12 years of experience in public health, she has dedicated her career to maternal and infant health. Prior to her current role, Tina worked 18 years in clinical experience as a labor and delivery nurse and the neonatal intensive care unit. In addition to her professional endeavors, Tina is a wife and a mother of 2 daughters. Throughout her career, Tina has been committed to providing families centered care. She is passionate about educating and supporting families, particularly supporting their breastfeeding journey. Today, Tina will discuss how the More Milk Sooner program, along with NIDA's support, was instrumental in sharing their framework. She is proud to share with us the accomplishment of her team in bringing this initiative to her community.
Thank you, Julie, for that warm introduction for Donna and I. So like Julie had mentioned, Donna and I are joining you from the Chatham Kent Public Health Unit. In 2024, our health unit decided to pursue initiating a More Milk Sooner campaign. So I'll give you just a little bit of a background on Chatham Kent. So in Chatham Kent, there we go, sorry. In Chatham Kent, we're comprised of about 12 small rural urban communities. We have 2 hospitals in our community, one in Chatham and one in Willisburg. Our Chatham site is our birthing facility. Chatham Kent Public Health Unit in Chatham Kent, we have about 993 live births in 2024. The Chatham Kent Public Health Unit was designated a baby-friendly facility in 2010. We redesignated in 2016 and are currently preparing to redesignate again this year. This More Milk Sooner campaign was important to us because Chatham Kent currently does not have a milk donor bank. And so implementing the More Milk Sooner campaign was certainly important for our community. The Chatham Kent Health Unit has been teaching hand expression in our prenatal breastfeeding classes for many years already. We were teaching about the importance of hand expression in the hospital, and our liaison nurse, who attends the hospital 6 days a week to visit our new moms and babes that have just been born, we provide them with this card that's on the left-hand side, and attached to it is a spoon that they are able to express into and use if needed to give supplementation of express breast milk. So the idea of a More Milk Sooner campaign started with the Breastfeeding Committee for Canada's 2023 National Breastfeeding Week webinars. Most of our team at the Chatham Kent Public Health Unit, the Healthy Growth and Development team, watched the seminar with Nada Hawkins, and our staff were very excited to learn more and to start to incorporate this into our practice. More Milk Sooner campaign was developed by our internal breastfeeding committee. We made the decision to start this campaign, and it also fit well into the theme in 2024 for National Breastfeeding Week, which was closing the gap, breastfeeding support for all. So our goal in implementing the More Milk Sooner campaign was teaching this simple technique of hand expression so that we could decrease the need for formula supplementation in hospital as well as when our moms go home, increasing mothers' confidence to provide milk for her baby, and to provide all the infants with an equitable start to life.
So I'm going to talk you through a little bit of our process. So just like Tina was saying, our internal breastfeeding committee attended the More Milk Sooner education session. And we were really excited about the potential of bringing this to Chatham Kent. We were seeing moms struggling in that first week to get breastfeeding established. I just want to say that we were always looking to amplify what NADA was already doing with Dr. Polius there. We weren't looking to recreate their website or any of their materials. We were looking at how do we bring this here and how do we amplify that. So that's how planning started. So we decided to take on the More Milk Sooner campaign. So we ordered some kits. We also made some of our own. We trained our public health nurses on our team. We developed a policy and procedures for our public health nurses to teach prenatal hand expression. I've shared that policy and procedure with the BFI team putting this together. So please feel free to share that. It was really important for staff to feel very comfortable and confident to be teaching prenatal hand expression and when it would be appropriate and when very rarely it would be inappropriate. We recruited a local physician. So Dr. Jackie Wolting here locally is very respected in our community, and she worked with us as our physician champion. We immediately collaborated with our local birthing hospital, not only for the support, but also to help educate their hospital nurses, as well as we partnered with our local midwives. Again, not only support, but making sure that clients across the Chatham-Kent region are getting the same information and education of their staff. So our physician champion helped us book our grand rounds in October 2024. And we booked NADA and Dr. Prolius to present the More Milk Sooner information as a hospital grand rounds. And we created physician packages. So our target was any physicians here locally that would be seeing women at that 36-week mark and beyond. So we targeted some family doctors who were still delivering babies in our region, all of our midwives, and then our obstetricians. For our campaign, we really wanted it to be targeted. So I think it was 12 of them, which obviously is like a small amount. We got really creative and fun with our package. I might have had a little extra money to provide, one of those little coffee tumblers. We were acting like some of the marketing experts on the other side of the fence. So we created a nice little coffee tumbler with like a Yeti and put the More Milk Sooner logo on one side and our Chatham Kent Public Health Unit logo on the other side. We included some colostrum collection kits in that package, a letter explaining what More Milk Sooner was all about and why we were promoting it. And we had some good response back from the physicians saying that, if this is something that we were promoting, that, they were going to look at it and promote it as well. So we included the printed posters from the More Milk Sooner Saskatchewan group. Again, I wasn't trying to reproduce anything. I ordered the materials from them and just helped amplify their messages, as well as we were looking at targeting the driving anybody who wanted more information back to that original website with the QR codes. So the More Milk Sooner QR codes were in the packages, sending, anybody sitting in a waiting room to NADA's videos, and as well as having like the collection kits with any healthcare provider here locally that was seeing a woman at 36 weeks. In the package, we also included some of the research articles, the client pamphlets, and again, the postcards. So we were really looking at anybody who was working with a woman at 36 weeks. It was going to be very easy to provide that information and education to the women coming into their office. We also included the More Milk Sooner materials in our own prenatal packages, as well as our breastfeeding classes and More Milk Sooner prenatal classes as well. We had gone to some of the sessions and we thought, why not open it up? So we might be driving some clients to NATA sessions because, it's good to have some virtual options for our clients. We also have our clients, they're able to come once a week to our breastfeeding clinic. We hold a breastfeeding clinic every Thursday afternoon. So if somebody wanted to work with a nurse one-on-one, they could come to our clinic and get those materials and work with them. Next slide. So our grand rounds, we worked with Chatham Kent Health Alliance. That's our birthing hospital here. We held our session with NATA and Dr. Prolius on October the 11th in 2024, and it was well received. For us to have 10 physicians and 26 nurses from the maternal child team was a real success to us. And the next slide. So we're looking to keep some momentum going. So all of our public health nurses teach prenatal clients how to do hand expression at about that, 35, 36 week mark. And through our Healthy Babies, Healthy Children program. And prenatal moms can attend that breastfeeding weekly clinic. We're proud to say that we're already seeing the collection kits come into the hospital. Our liaison nurse sees them at the bedside and people are bringing them in. And working with our partners has helped to make sure that, storage and handling pieces are taken care of at the hospital and that moms are supported when they bring in their kits, that they're stored properly there. So we will continue to collaborate with our hospital partners and midwives. Our barriers, we didn't really experience any barriers this time along. And, originally when we were asked to do this presentation, we were asked about any challenges or solutions. And what I was kind of thinking is, wouldn't it be great if there was a policy that, all obstetricians, all midwives, anyone seeing, women during the end of their pregnancy had all this training in breastfeeding. That's my, big picture, thinking on policy pieces and education changes. And the impact on staff, making sure that we have policy and training for our staff is really important. So I wanted to make sure that everybody had confidence and skills, and not only to teach it, but to feel comfortable with, feeling good about teaching their clients how to do prenatal hand expression, and collaborating with our community partners to make sure that we are working together. And like I said, we're increasing moms' confidence and skills in those early hours. And that's it from me. So I just want to say thank you. Thank you to NATA and Dr. Prolius for starting this work. Thank you for continuing to contribute to it. We just recently bought some more kits. While I still have a budget and can still get these things free to our local clients, we're going to do that. I did tell my midwives that maybe in the future I'll be reaching out to them to help supply kits because we're going to try to keep them available to everybody for free while we can, and continue to grow the momentum. So thank you so much for starting this important work, and we appreciate your leadership in that piece.
Thank you, Donna and Tina, for sharing your insights on the Chatham Kent experience in implementing antenatal hand expression in public health.